So, good evening and a warm welcome to all the dignitaries present here. I'm Sreyushi from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event, hosted by the National Neonatology Forum, and the focus of today's session is NNF Shine Week 1 is Zone. So let's begin today's session, for which I would like to invite Dr. Rita Bora ma'am to take over. Over to you, ma'am. Kindly proceed with the talk.
Okay, thank you so much, Shreyasi. Yeah. At the outset, I'd like to thank the office bearers of NNF, Dr. Shushwan Angia and Dr. Surinder Bist, for organizing this excellent learning program. And it's really an honor for me to be present here and talking on the first learning program, which should be online today. So we have already had the topics distributed in the WhatsApp group, and probably most of the students have gone through it. So this will be a learning process, which should be also a recapitulation of what we have learned over the week. So Dr. Surinder Bist, would you like to say something, please?
Madam, that's great. And congratulations to all the East Zone participants, the students who are fortunate to be blessed with this kind of program in their first year of training. And Dr. Shishwan Angya, in her presidential action plan, has thought of actually improving neonatology teaching in medical colleges across India. And for this, you would be glad that you are part of around 2,000 students, MD students across India who will benefit from this program. So doing this program will make you at par with this, and for your super specialty exam, for your career, for your residency programs later on, or for your NNF fellowship, or for international fellowships, which NNF offer, Canadian or Oxford University fellowship, which NNF offers. So if you have done so, you will be doing great in those exams. Over to you, Dr. Rita Bora. Thank you, madam, for taking up this.
Yeah. So thank you for being present also. And then probably we should be starting with the topic. Okay. Yeah. I'll be sharing. Okay, it's not coming. I hope it is visible. Hello. Yes, Shreyasi, is it visible?
Yes, ma'am, it's visible. Please continue.
Yeah. So welcome all students. Mostly all of you are first year students. So I welcome you to this learning program now. And I'll be discussing on the first day the care of normal newborn during the first golden hour and beyond. So birth is a crucial process of transition from intra to extrauterine life. And large majorities will make the smooth transition and get shifted later to the extrauterine life. But some of them may not do so. So we need to monitor them. And also we need to monitor them because they are at risk of hypothermia, feeding difficulties, etc. So although they are normal babies, but then still there is need for monitoring all these babies for different conditions like hypothermia, feeding difficulties, and sepsis. So today we'll be trying to learn how to provide care at birth, screen babies for visible defects, and also how to provide postnatal care for normal babies. So let us just talk about a baby who was born yesterday. And I would request all of you to pay concentration to this story so that from this story, we learn how to manage a normal baby in the labor room as well as in the postnatal ward. So this baby who was born to Mrs. P, the mother was a 24-year-old primigravida mother with term pregnancy and in labor. So a call was given to the SCNU nurse, and this nurse was a newly recruited one. So the obstetric nurse delivered the baby, and the cry was heard as soon as the baby was delivered. Cord was clamped within 30 seconds. Baby was brought to the radiant warmer, wiped dry, and the cord was tied. The nurse observed the baby for heart rate, respiration, and color. As the baby was stable, baby was taken to the weighing scale and weighed. Then the baby was brought to the radiant warmer, given vitamin K injections, then shifted to a cot as one more baby was going to be delivered. Now the baby remained in the cot unclothed, yet till mother was shifted to the postnatal ward after 1 to 1.5 hours. Then during transfer of the baby into the postnatal ward with the mother, the nursing shift changed. So a new nurse came and she became confused regarding which baby to shift, whether it was the baby of Mrs. P or somebody else's baby. She was confused because there were two babies in the cot. So she felt that both babies' feet were cold. That is that babies were having hypothermia, cold stress was there. She asked the mother P which baby she identified as her own, and then advised her to wrap the baby and to start breastfeeding. Now, today in postnatal ward, mother complained that the baby has not passed stool since birth because it is almost over 24 hours, and the doctor on duty when examined, he found that there was an imperforateness. So this is the story, and I would urge all of you to remember this story. Now, coming back to the discussion, what are the aims of neonatal care following birth? The first is that we have to understand that a baby has establishment of respiration. We also need to prevent hypothermia. Establishment of breastfeeding should be there, prevention of infection, and detection of danger signs. So at least these 5 things should be done in the labor room. Establishment of respiration, prevention of hypothermia, establishment of breastfeeding, prevention of infection, and detection of danger signs. Now, what is the concept of golden hour? The concept of golden hour, introduced recently in neonatology, highlights importance of neonatal care in the first 60 minutes of postnatal life. The neonatal management in the first hour of life have an important effect on both immediate and long-term outcome of all neonates. There are many interventions that needs to be practiced in the golden hour for neonatal care so that neonatal complications are minimized. A standard approach is followed, derived from the best available evidence, with aim of practicing gentle but timely and effective interventions with non-invasive procedures if required for a better outcome. Now, what are the components which can be practiced in the Golden Hour project for better neonatal outcome in normal term newborns? First is that we need to take antenatal history, and also we need to form a team for taking care of these babies, and team briefing has to be there. Then proper resuscitation should be done at birth. Proper cardiovascular support by delayed cord clamping and skin-to-skin care. Proper identification and documentation. We need to check for malformations and birth trauma. Prevent hospital-acquired infections by proper asepsis maintenance. We need to provide proper nutrition by early initiation of breastfeeding, thereby preventing hypoglycemia. We also need to communicate with parents regarding baby, and also communicate between the health workers and in the labor room and in the postnatal ward. So this is very important. Communication has to be there between all health workers who are working in the labor room as well as in the postnatal ward. There has to be methods of prevention of hypothermia by giving skin-to-skin care as well as by initiating breastfeeding. And we need to do periodical monitoring of vitals, and vitamin K injections should be given intravascularly. So these are the components of the Golden Hour project. Now, how should we take care at birth? The same, irrespective of kind of personnel attending delivery and place of birth. So every baby who's being delivered, whether the baby has been delivered in a medical college, in a district hospital, in a PSC, or in a small health facility, or in the private setup. So everywhere, irrespective of where the baby is being born, or whoever is attending the delivery, the care should be similar. A detailed history of mother antenatal period should be taken. A proforma is helpful to avoid missing important clinical points. So ideally, all health facilities where deliveries take place should have a proforma so that important clinical points are not missed. At least one healthcare person with skill and knowledge of neonatal resuscitation must be available during each delivery. Team formation and allocation of responsibility before delivery has to be done, and all equipment needed for resuscitation should be available, functional, and sterile. Now, in our unit, for those students who are working here, we have a neonatal proforma that you are now used to using it. So it has all details regarding the mother, like her name, address, parity, gravida, and what is her LMP, the expected date of delivery, blood group, her hemoglobin, the blood pressure, whether it's primary or multi, and then for how long she had been married. Then we would take also regarding her histories, like medical problems. We would also take history regarding obstetrical problems. Then we'd also take history of her previous pregnancies, and every detail of neonatal resuscitation as well as the vitals would be included in the proforma. So this proforma helps us to keep all the records which are required in the labor room. So as we have already mentioned, maternal details like basic details, address, etc., parity, gravida, blood group, blood pressure, blood sugar, hemoglobin. Then regarding antenatal period, which is divided into first trimester, second trimester, and third trimester, all details regarding these trimesters are included. Then antenatal medical and obstetrical problems, test results, like urine routine examination, the screening procedures like HIV and hepatitis B, syphilis, all these routine tests which are being done for the mother should be taken into account and documented there. The test results should be documented. Then duration of labor, rupture of membrane, whether there was any meconium stained lager, the mode of induction, the mode of delivery, resuscitation details, anthropometry. Just after delivery, once the baby is being stable, we would also take the anthropometry, which includes weight, length, and the head circumference, and that would be put in the chart. Then examination findings, any congenital malformations, the vitals before transfer to the postnatal ward, whether vitamin K injection has been given, where the baby has been transferred, the transfer area, whether to the postnatal ward or to the NICU, and the transfer vitals all are recorded. At delivery, the umbilical cord management, what should be the routine? So timing of cord clamping should be 1 to 3 minutes after birth. So this is delayed cord clamping. So this should be a routine, and it should be clamped by a sterile clamp, rubber band. Cord needs to be kept dry, free of any application. So we are all aware of it, but still these are some things which we need to keep in mind. So if we tie the cord with some threads, then there is a risk that the tie would become loose after some time as the umbilical cord shrinks, and there are chances for bleeding. So ideally, sterile clamps which are available now commercially and rubber bands can be used. Now, WHO recommendation on newborn health, document says that cord clamping should be done at 1 to 3 minutes after birth for all babies while initiating simultaneous essential newborn care. Early cord clamping is not recommended unless the neonate is asphyxiated and needs to be moved immediately for resuscitation. So this we have to keep in mind. And skin-to-skin contact, newborn without complications should be kept in skin-to-skin contact with their mothers during the first hour after birth to prevent hypothermia and promote breastfeeding. So all babies who are more than 30 weeks of gestational age, if stable hemodynamically, should be kept in skin-to-skin contact with the mother. Now, skin-to-skin contact some details regarding that. So mother should be in slightly reclined position. Baby is placed on the mother's abdomen, dried and covered with a blanket until cord is clamped. So just after the delivery of the baby should be put on the mother's abdomen. The person who's delivering the baby should cry out the time, and then every 15 seconds, the time would be told by the nurse who's assisting. And then once it is 1 minute, then the cord would be clamped. So skin to skin contact and cord clamping should be done in that manner. Once the cord is clamped, baby is placed chest to chest with mother and remains there uninterrupted for at least 1 hour, and preferably until the first breastfeeding is completed. This provides optimal physiological stability. Baby's face is easily visible and uncovered, neck is straight and knees are bent. Baby may be naked or diapered and remains warm due to skin-to-skin contact with the mother. Baby can be dried during process of placing skin to skin. Then baby and mother are covered with a blanket. Other tests like Apgar scoring can be done while the baby is being held skin to skin. Most other standard procedures like vitamin K shot can be done while the baby is on mother's chest. Baby's measurements can be delayed for up to 6 hours. So the anthropometry, as I have already mentioned, once the baby is stable, then only we should be doing. And that can be delayed even for up to 6 hours because it's not going to lead to any dramatical change during this time frame. Baby and mother are monitored by nursing staff during the skin-to-skin care. Mother notices baby's feeding cues like rooting or sucking on hands and then can guide the baby to breast for first feeding. Skin-to-skin contact can continue as mother and baby are moved to postpartum setting with proper observation. So skin-to-skin contact helps early stabilization of heart rate, respiration, stabilization of body temperature, easier transition from in utero life, initiation of breastfeeding, normalizes blood sugar, development of good microbiota is also there. There is reduction in crying and improved bonding. So we can see that just after birth, there are so many things which can be stabilized for this newborn baby by this simple method of skin-to-skin care. And this should be a routine in the labor room. Delayed cord clamping, which is done along with skin-to-skin care, means more blood for the baby and less for the placenta. So we can see here in this picture that if we clamp the cord within 15 seconds after delivery, much of the blood remains, almost 90 ml of blood remains in the placenta, while baby gets only 15 ml per kg. So if it is delayed up to 60 seconds after delivery, 60 ml of blood would be there in the placenta per kg, whereas the baby would be getting around 45 ml per kg of blood. So that makes a lot of difference with improving hemodynamic stability right after birth, as well as there are evidences that in preterm babies, it would also prevent many things like intraventricular hemorrhage, necrotizing enterocolitis, etc. And along with that, it would also increase the iron store for future life, like in the infancy. Now, the next step is baby identification marking. So it might seem to be a very trivial thing, but it has got a lot of importance. This is important for safety of all newborn and family. We need to follow the local guidelines for identification. In our SCNUs, mostly in our SCNUs in Assam, we take the footprint. Responsibility is of attending nurse to take this identification. Additionally, tag needs to be used, and it should contain name of the mother, date and time of birth, gender, and birth weight. It is important for reconfirmation of gender in a busy labor room. Handwriting should be legible, and ideally there should be a barcoded identifier, which may be available in some hospitals, but we are still not using it. But ideally, this should be used. Now, why identification is needed? Because hospitalized newborns are a vulnerable population at considerable risk for misidentification. Many newborn with similar birth dates are there in the same area, and medical record numbers can also be similar. So multiple will have identical surnames and be hospitalized at the same time. They are unable to speak, hence they cannot participate in confirming identities. They also lack any distinguishing physical attributes and characteristics. So most of the newborns would look similar. Furthermore, well-known misidentification errors such as wrong patient, wrong procedure have resulted in many errors, including providing 2 vaccines to the same infant, wrong infant being given antibiotics, feeding of a mother's express breast milk to the wrong newborn, and giving a breastfed infant formula or a mother breastfeeding the wrong infant. So lots of mistakes can happen if identification is not proper. So identification marker has to be there for each and every baby. Now, 2 identifiers are better. So footprints as an identifier, but the challenges are that it's difficult to take sometimes because the newborn's baby's skin is covered with oily substances. So we know the vernix caseosa is there. So many times it might be difficult. Then there is reduced thickness of the newborn epidermis, easily deforming the ridges upon contact and filling the valleys between the ridges with ink. So there is also reduced size of the newborn ridges, which are 3 to 5 times smaller than that of the adults. Additional use of tag bands adds to the security. So it's very important that we get tags. Checking identity bands while neonate is transferred from one area of the hospital to the another area, like from the labor room to the postnatal ward, by receiving nurses, very, very important. So whenever a baby is being transferred, that it should be a routine that we check the identification tag. Compliance needs to be checked periodically. And if these tags are damaged, we need to replace it immediately, double checking for correct information. And we also should counsel the parents regarding preservation of the identifier. Now, the next important thing which we have known in the component of the golden hour care is prevention of hypothermia. So there is 28% increased risk for neonatal mortality with each 1 degree fall in auxiliary temperature while the baby is admitted to the NICU. We can understand the importance of maintaining normothermia by looking at this statement. Admission temperature NICU is a strong predictor for neonatal mortality. The highest risk of neonatal hypothermia is within the first minute to hours after birth, as there is wide difference between in utero and the environmental temperature. So inside the mother's womb, the baby is at a temperature of 37 or maybe even 38 degrees centigrade because it is inside the womb. And as the baby comes out to the environment where maybe the room AC is on for the comfort of the mother or the people who are working there, kept at 23 or 24 degrees centigrade, we can imagine that there is a difference of 11 to 12 degrees centigrade all of a sudden, which can make the baby very much hypothermic. Afterward, there is rapid loss of heat by conduction, convection, evaporation, and radiation that we all know. And the neonate develops hypothermia because of large surface area per unit body weight, high surface area to volume ratio, increased evaporative fluid losses from the skin, very large surface area of head compared to the body, and presence of thin layer of subcutaneous fat, thus making them susceptible to easily develop hypothermia. Hypothermia leads to significant increase in Apgar score, less than 7, late onset sepsis, hypoglycemia, and respiratory distress. Hypothermia can be prevented by keeping the delivery room temperature from 26 to 28 degrees centigrade and by doing skin to skin care, and also after the baby is stable, like we can put the baby with caps and socks. Now the next step is initial weight recording. So weight only after stabilization on a digital scale with plus minus 5 gram accuracy. So we have mentioned earlier that it can wait up to 6 hours because the weight is not going to change within this period. So there is no hurry in weighing the baby immediately because that makes the baby hypothermic. Place a single-use paper towel on the scale before using, clean weighing scale before and after use, and calibrate the weighing scale at least twice a week. So that needs to be done in the labor room. Now, next step is initiation of breastfeeding. So initiate as early as possible. Breastfeeding should be initiated as early as possible with skin to skin care on labor table itself. Assist the mother in helping baby to breastfeed. So it's not good enough to say that, okay, now you can feed the baby, so start feeding, but we need to assist the mother by helping the baby to breastfeed. Counseling alone without assisting is unlikely to lead to high success rates in breastfeeding. So it's very, very important that we help the mothers in breastfeeding in the labor room. And it is why it is so important. because there is 15% reduction of neonatal mortality if early initiation of breastfeeding is done in the labor room itself. Next is importance of giving vitamin K. Now we know that vitamin K injection prevents vitamin K deficiency bleeding in neonates, and it should be administered intramuscularly on the anterolateral aspect of thigh using a 26 gauge needle. So that has to be remembered. We should not be using a very big needle, but it should be a very small one. 26 gauge needle should be used, and the dose is 0.5 milligram for babies who are less than 1 kg and birth weight, and those who have birth weight of more than 1 kg, the dose is 1 milligram. Next important thing is screening for life-threatening malformations and birth injuries. So after the baby is being delivered and is in skin-to-skin contact with the mother and stable, we need to examine thoroughly this baby for life-threatening congenital malformations and birth injuries and document the findings. Examine the midline structures for malformations like cleft lip, palate, neck masses, chest abnormalities, omphalocele, anorectal malformations, and meningocele. There is no need for routinely passing a catheter into the stomach, so no need to give a stomach wash, not even for cesarean section babies, because many hospitals have that um, procedure done as a routine for all cesarean section babies, but it should not be done. We need to examine for life-threatening birth injuries like subgaleal bleed. Now, some defects can be diagnosed at birth, and we have a chart which is provided by the RBSK in the RBSK guideline book. And this is also available as a poster to be placed in the labor room. So neural tube defects, Down syndrome, cleft lip and palate, talipes, developmental dysplasia of hip, congenital cataract, congenital heart defect, all this can be identified at birth. And some of the malformations can be matched with the pictures which are there in the poster and then can be identified very quickly. So such posters should be available in the labor room. So examination of a newborn, we have already mentioned few things. So we need to go for general observation, weight, length, head circumference, gestation, overall observation of movements and tone. Then in the head and neck, we need to look at the fontanelle, the facial appearance for dysmorphic features. Then in the eye for cataract and red reflex, in the mouth, cleft lip, cleft palate, central cyanosis. So sometimes what happens is that the baby may not have a cleft lip, but there can be a cleft palate. So if cleft lip is there, then it is easy to be found out. But if there is only cleft palate without a cleft lip, unless we examine the oral cavity, we would not be diagnosing that condition, and the baby may be at risk for aspirations at times. So we need to check the oral cavity as well. We need to look at the upper lips, digits, any abnormal palmar creases, abdomen, for abdominal distension, enlarged liver, spleen, kidneys, or a mass. The hips should be looked for developmental dysplasia of the hip. Lower limbs should be again examined for any talipes, positional equinovarus. Genitalia and anus should be looked for any presence of hypospadias, undescended testis, ambiguous genitalia, anal position and appearance. The pulses should be felt in the femorals for detection of any heart disease like coarctation of aorta. Chest should be examined for any respiratory abnormality, chest retractions, heart sounds and murmur, and skin should be looked for any pallor, jaundice, plethora, etc. So what are the criteria to say that the newborn who is being delivered is at-risk newborn and needs admission to the SNCU? So if the birth weight is less than 1.8 kg, gestation less than 34 weeks, if there is any major malformations, birth asphyxia, needing more than bag and mass ventilation, or respiratory difficulties, so these babies need admission into the SCNU. Now, the next step is communication with family. The healthcare provider must communicate with the family regarding time of birth, the birth weight, the gender, condition of the baby, condition of the mother, and baby should be shown to the family members with particular attention given to the gender and identification tag of infant. It's very, very important to let the parents know as well as let them identify the gender, because in many societies there are preferences for certain genders and there can be confusions and claiming that there is another gender, whereas actually the baby who is born is of different gender. So we need to be careful about the gender. apart from the all other things which we have told already. Now, coming back to the story which we had in the labor room, what are the things which were not done correctly and what are the things after we have learned about the golden hour would have been done in a different way for improving the survival of the newborn. So if you look at this baby of MP was delivered to a primigravida mother who was 24 years old, who had been admitted to our labor room. We had seen that the delivery was when the delivery was imminent, a call was given to a nurse who was recruited very recently. But from our, learning now, we have understood that it should be attended by a trained, skilled personnel. So every delivery should be attended by a trained, skilled personnel. Now, obstetric nurse delivers the baby, cries hard as soon as the baby is delivered. So there was no asphyxia, but the cord was clamped within 30 seconds. So there should have been delayed cord clamping. So baby's cord should have been cut only after 60 seconds. So delayed cord clamping is indicated. Then the baby was brought to the radiant warmer, wiped dry, and the cord was tied there. So it should have been actually put on the mother's abdomen just after delivery for skin to skin care. The nurse observed the baby for heart rate, respiration, and color, but then she did not include temperature monitoring. So this is another thing which she should have done. So temperature should be included as a very important parameter while monitoring babies. As stable baby, as this was a stable baby, baby was taken to the weighing scale and weighed. Now we have learned that weigh only when all vitals, including the temperature, is stable. So weighing can be delayed even up to 6 hours after delivery, because that is not going to make great change. This timing of 6 hours is not going to make difference in the birth weight. Now this baby was brought to the radiant warmer and given vitamin K, then shifted to a cot as one more baby was going to be delivered. But what actually should have been done, this baby should have been with the mother in skin to skin contact at least for 1 hour. Baby remains in cot unclothed yet till the mother was shifted to the postnatal ward after 1.5 hours. But what should have been done? Baby should be on skin to skin care with the mother. During the transfer of the baby to the postnatal ward with mother, shift changes and the new nurse comes who was confused. She could not identify the baby properly, whether this was the baby of the mother Mazoni or it was somebody else's baby. That was not clear to her. So what was needed? A proper identifier, documentation, and handover was indicated. So when the first nurse was changing because of her ending of shift, she should have given bedside handover with proper identification of the baby, and a proper identifier should also have been there in the baby. The nurse who was shifting the baby felt that the baby's feet were cold, but then she did not do anything about it. So what she should have done, she should have stabilized the baby before transfer. So rewarming should have been done. She asked mother to be transferred, which baby should be transferred. She asked the mother. So what should have been done? She should have called the mother by name, assist in KMC and breastfeed, identify the baby using the identifier. So all this should have been done. She did not tell her how to breastfeed the baby and also how to do KMC. All these were not told. Now in the postnatal ward, after 24 hours, mother said that the baby was not passing stool, and the on-duty nurse again discovers that there is imperformance. Again, life-threatening malformation should have been screened in the labor room itself and identified. So there are lots of things which are sometimes missed in the labor room, but we need to correct. Once we have this knowledge now, we should be correcting ourselves and doing all this according to the norms. Like, we have to understand that the golden hour has many components, and all these components should be done very nicely so that the babies do not suffer later on. So we have completed the care within the golden hour. Now, what is the care beyond golden hour? So we need to observe baby in the postnatal ward twice at least by the medical officer and the nurse in the postnatal ward. And what are the things that we need to observe? We need to look at the cry, activity, reflexes, whether there is adequate establishment of breastfeeding. We need to maintain the temperature of the baby within the normal area, that is between 36.5 to 37.5 degrees centigrade. We need to look for any presence of jaundice, whether the baby has passed urine meconium, that needs to be looked for. So stool should be passed, meconium should be passed within first 24 hours, and urine should be passed at least within next 48 hours. We also need to look for any presence of danger signs. Now, if you look at these two pictures here, we can see that the first baby looks quite active, is alert, looking nicely, but the other baby looks pale, little cyanosed and drowsy. So all these activities, whether the baby is sleeping actually or drowsy or like inactive, that needs to be looked at. We need to establish that there is adequacy of breastfeeding. So mere advice is not adequate for establishing breastfeeding, but we need to assist in positioning and in attachment. We need to reassure the mother that initially in the first 2 to 3 days, there is small volume of breast milk which comes up, which is adequate for the baby to provide the adequate nutrition. And we need to counsel even the family, because many a times the families, if they do not understand, they might force the mother to feed something apart from breast milk. So we need to counsel the family as well, and we need to encourage and appreciate the mother. So this point is very important. Within the first 2-3 days, as the colostrum is being produced, the milk output is less, and many mothers do feel that their output is less. They are worried, anxious, and start feeding with something else like a formula rather than going for demand feeding of the baby. And that makes breastfeeding failure. So we need to understand that and counsel families regarding this. Now, weight record is again important. Most healthy babies lose weight for initial 2 to 3 days. Loss can be up to 5 to 10%. Weight remains stationary for next 2 to 3 days and then regained by end of the first week. Preterm babies may lose up to 2 to 3% of body weight per day, maximum of 15%, regaining birth weight by 14 days. The weight loss of more than 5% per day is abnormal. Delayed feeding and unsatisfactory schedule may increase weight loss. Adequately fed baby passes urine 6 to 8 times per day, and average weight gain can be 20 to 30 grams per day. Now, next is evaluation for jaundice. Examine on daylight twice a day for first few days. Although physiological in most neonates, very rapid rise or excessive increase of TSB level can be dangerous. So the course of physiological jaundice is shown in this slide. We can see that it starts beyond the first day, usually by 30 hours of life, and then doesn't reach more than 15 milligram per deciliter. And the peak is reached by 5 to 6 days, and gradually it decreases. It disappears by the end of second week for term babies, and for preterm babies, it may go a little bit longer. So yellow staining of soles are dangerous because the level can go beyond 15 to 18 milligram per deciliter if it is staining the palms and soles, and it is a danger sign. So that needs to be checked. And there are also ways of anticipating whether the baby is going to have hyperbilirubinemia in next few days by looking at the nomograms. These are Bhutanese nomogram, which can help us to identify the risk by doing the TSB level at 24 hours. So we'll go into details of this later on when we deal with jaundice and other conditions later on, but just this is an introduction regarding the management of jaundice. So for babies who have jaundice, we have to find out what is a TSB level, and then we plot it in the nomograms and find out whether the baby needs phototherapy or other treatments based on these nomograms. So one thing which I would like to say here, that there is a condition called breast milk jaundice, which is very commonly said by the postgraduate students. But then you have to understand that there is no risk of breastfeeding in this condition. Discontinuation of breastfeeding is not recommended either for diagnosis or for treatment of breast milk jaundice in neonates. This is according to the CPG Clinical Practice Guidelines from National Neonatology Forum published in 2019. Prophylactic phototherapy is also not recommended for management of neonates with RS immunization or ABO incompatibility. So although the setting is there, unless the baby is jaundice, we would not go for prophylactic phototherapy in these settings like ABO incompatibility or RH immunization. So these two things are important for us to understand. Now, developmental variations and physiological conditions should also be taken into account. So knowledge regarding developmental variation, physiological conditions, and their evolution is very important. There can be sometimes vomiting, which is a common problem amongst newborns. The cause is mostly faulty feeding technique or aerophagy. If persistent, or if there is blood or bile stained vomitus associated with abdominal distension, then we need to investigate. But if the baby is otherwise taking out small volume of milk, and then there is no difficulty in passage of stool, there is no blood staining or bile staining, then we need not worry. Now, stool pattern and color is also very important for us. Breastfed neonates can pass frequent golden yellow stool. Reassure mother if gastrocolic reflex is active, because every time the baby takes some milk, there can be passage of stool, and the mother may be worried thinking that this is diarrhea. So reassure the mother that this is gastrocolic reflex which is active, and this is leading to frequent stooling. Increased frequency in breastfed baby should not be confused with diarrhea. Some may not pass stool for 5 to 6 days if on breastfeeding. Now, there can be sometimes blood in stool which needs to be investigated. Many a times vitamin K deficiency bleeding can present in such manner if the baby had not received vitamin K at birth, or if the baby has some conditions which is leading to this, like a mother taking some medications. Then there can be sometimes delayed passage of stool because of meconium plaque. So this is one picture of meconium plaque. So once enema is being given and this is released, the baby would be passing stool normally. Now there can be sometimes excessive cry. Babies usually remain awakened at night and sleep during the day. So this is a common condition amongst the newborns, and we need to reassure the parents about this. They can also cry because of hunger, discomfort of full bladder, soiling of diaper, etc. So why the baby is crying, that needs to be looked at, and the cause should be removed. Persistent crying, however, needs evaluation because it can be because of pain or inflammation. Now, regarding care of cord, baby's cord should be kept dry. Nothing should be applied on the cord, and the cord should be examined every day for any discharge or foul smell. Now, some features may be normal, which needs reassurance for the parents, like an abstain pearl. So we can see in the first picture that there are 2 spots in the palate, whitish spots. These are known as abstain pearls. So these are normal findings. Erythema toxicum is quite commonly observed in neonates. These are maculopapular rashes, which disappear and reappear again, mostly seen in term babies. So these are also benign conditions. And stroke bite, which is quite common. As you can see here, a red patch can be observed at the back or any other part of the body, which is a capillary hemangioma, which would progress initially, enlarge initially in the first year, and then gets healed by itself over the next few years of life. What are the advice that we need to give at discharge? To maintain body temperature, to continue with breastfeeding, and maintain hygiene. So these are the 3 most important advice which we need not forget. So maintenance of body temperature by allowing the baby to put warm clothes before dressing baby, especially in winter. So like we need to pre-warm the clothes before dressing the baby, especially in the winter. So clothing should be given properly. So there should be a cap, there should be mittens, and then warm clothes should be there to swaddle the baby. And all this should be pre-warmed before use. Breastfeeding should be continued every 2 to 3 hours. So this should be semi-demand. If the baby is not waking up by 2 to 3 hours, then we need to wake up. If the baby wakes up earlier, at 1.5 hours also, then and demands feeding, that should be given. Nothing apart from breast milk should be given during this period. We also need to maintain hygiene, so prevent drugs during birth, keep baby clean, Low birth weight babies during winters can be sponged to avoid hypothermia, and we also need to take care of the eye and the cord. Immunization advice needs to be given to the parents. Birth dose should be given in the hospital. BCG, zero dose polio, and hepatitis B. This we all know. We need to advise for complete immunization. And also, if the baby is there and we have a facility for newborn screening, this should be done within 72 to 96 hours of age. Danger signs should be explained to the mothers. What are the danger signs? Bleeding from any side, appearance of jaundice within 24 hours of age, or yellow staining of palms and soles, failure to pass meconium within 24 hours, or urine within 48 hours, persistent vomiting, poor feeding, undue lethargy, excessive crying, drooling of saliva or choking during feeding, respiratory difficulty, apneic attacks or cyanosis, sudden rise in or fall in body temperature, seizures, or evidence of superficial infections such as conjunctivitis, pustules, umbilical sepsis. All these are danger signs, and we need to talk to the parents regarding this so that they can bring the baby earliest possible to the hospital if such signs occur. Traditional practices, what should be told about them? So there can be harmful practices like shaving the head. So this should be discouraged. Just after delivery, if the baby's head is shaved, there is risk for hypothermia as well as injury. So such kind of practices, harmful practices, should be discouraged. Helpful ones should be encouraged, like isolation of the baby and the mother for at least 1 month is a common practice amongst certain societies. So that can be helpful for prevention of infection. So that can be encouraged. And some things like putting tikka, like just to on the forehead of the baby, may not be harmful, and that can be continued. However, we should not allow them to put kajal in the eyes. That is a harmful practice. Now, checklist before discharge: no active problem, immunized, adequately breastfed, mother is free of any illness, confident to take care of baby, and mother has been counseled regarding newborn care, danger signs, need for follow-up and continuation immunization. So all this when done, so we can discharge the baby and mother do. Now, what about follow-up in well baby clinic for assessment of growth and development, early diagnosis of any illness, if any, and follow-up should be planned for community and institutional follow-up. Ashas can follow up them in the at home. So that should also be informed. Okay, so this is all about care of a term newborn. So if anything is there, probably we can discuss in the chat box. Yes, Shreyashi. Hello. So next would be
Yes, ma'am.
yeah. So should I start with the next one?
Yeah, sure, sure. Please.
Any queries in the chat box? Nothing.
Let me check, ma'am. No, ma'am. No question
Okay.
we have received yet.
Okay. So I'll go to the next
Yeah,
topic.
sure,
It
sure.
is short. So
Please continue, ma'am.
yeah. Okay. So the next topic is regarding thermal control. So our objectives for learning would be the mechanism of heat loss, concept of warm chain, recording of body temperature and grade of hypothermia, prevention and management of hypothermia, fever and management, and advice at discharge. So this would be a short presentation. So neonatal hypothermia is an important cause of neonatal death. So in the first section, we have learned that skin to skin contact is very important, and it can prevent death in the newborn. So it's very important that we prevent hypothermia of newborns in the labor room itself. Now, and then again in the postnatal ward and later on as well. Hypothermia can lead to hypoglycemia, bleeding diathesis, pulmonary hemorrhage, acidosis, apnea and respiratory failure, shock, and eventually death. Now, why newborn babies are prone to develop hypothermia? So we have discussed about this earlier. So there is large surface area of the body of the baby, decreased thermal insulation due to lack of subcutaneous fat, reduced amount of brown fat in the low birth weight babies. So we know that there is some brown fat in different parts of our body, like in the axilla, around the aorta, then around the adrenal. So these are areas where there is highly vascular area of fat. And when there is hypothermia, there are changes which occurs there. There is release of hydrolysis of fat, and then there is release of glycerol and fatty acids, and glycerol is again utilized for production of heat. And then through this vascular supply, which is there in the brown fat, the heat gets dissipated to different parts of the body. So this amount of brown fat, which is there in our body, is very low in the low birth weight infants. There is also lack of shivering. So now what is the mechanism of heat loss? So we have all studied regarding this earlier. So we know that heat is lost by 4 different mechanisms. One is evaporation, second is conduction, third is convection, and fourth is radiation. So evaporation is there in the newborn babies when there is evaporation of amniotic fluid from the skin surface. Then when the baby is kept in a tray, which is cold just after delivery, it comes in contact with this cold object and there is conductive heat loss. Convection can be there with leading to heat loss when air currents in which cold air replaces warm air around the baby. So the air around the baby would get heated because of the baby's body temperature, which will then get replaced by cold air, and thus the baby becomes cold due to convection. And radiation heat loss can also be there from the baby to colder objects in vicinity, like the walls or any other metal objects which can be there nearby, can also lead to radiation heat loss. So the 4 ways of heat loss in the neonates are being shown here: conduction, convection, evaporation, and radiation. Out of this, mostly the most important method by which heat loss occurs in the labor room is evaporation, because the baby is covered with amniotic fluid, and once this fluid is evaporated, there is also heat loss along with that. Now, we need to understand the concept of warm chain. This is a set of 10 interlinked interventions to minimize the likelihood of hypothermia at birth. So warm delivery room, so temperature of the delivery room should be between 26 to 28 degrees centigrade. Warm resuscitation, immediate drying and removal of wet linen, skin to skin contact, breastfeeding, postponing bathing and weighing, so that we have understood in the first chapter. Then appropriate clothing and bedding, rooming in, warm transportation, and awareness raising of healthcare providers. So everyone should be knowledgeable regarding the hazards of hypothermia and how to maintain the warm chain for all health workers who are working in the labor room. Now, what is hypothermia? So normal temperature is 36.5 to 37.5 degrees centigrade, that we all know, 97.7 to 99.5 degrees Fahrenheit. Temperature below 36.5 degrees centigrade is hypothermia. Now, if the baby is having temperature between 36.4 to 36 degrees centigrade or 97.5 to 96.8 degrees Fahrenheit, then this is cold stress. If the baby is having temperature between 35.9 degrees centigrade to 32 degrees centigrade, it is moderate hypothermia. And babies having less than 32 degrees centigrade are having severe hypothermia. So there are 3 methods of temperature recording. So axillary temperature can be taken, then we can also use rectal temperature, and then we can go for skin temperature. So axillary temperature is as good as rectal and it is safer. Rectal thermometer is has a facility for detecting temperature which is quite low, less than 30 degrees centigrade. But then mostly it is avoided because of risk for injury. So we are using auxiliary temperature mostly now, which can be digital thermometer. Now the mercury thermometer is no more used. We use digital thermometer. So when the temperature is being measured, we put the metal part of the digital thermometer after cleaning it properly in the axilla, and then once the beep is there, then we record what is the temperature. That shows the equilibration of the body temperature with the thermometer, and then we record the temperature as the baby's temperature. Now we also have thermistor probe, which is attached to the skin over upper abdomen, and it displays it on the panel of the radiant warmer. So human touch can also help to assess the temperature. Abdominal temperature is representative of the core temperature. So we can touch with the dorsum of our hand on the abdomen and also compare that with the sole. If the abdomen and feet are warm to touch, then the baby is at thermal comfort. If the abdomen is warm but the feet are cold, baby is in cold stress. And if both feet and abdomen are cold, then the baby is having moderate to severe hypothermia. Now, what are the clinical signs and symptoms? Lethargy, irritability, poor feeding, poor weight gain, breathing difficulty. Severe hypothermia may manifest with hypoglycemia, sclerema, DIC, as well as bleeding. Now, how do we prevent hypothermia? So at birth, by using the routine care. So preventing heat loss at time of birth is shown here by drying the baby, wrapping up properly along with the mother while being on skin to skin contact and allowing the baby to breastfeed. So when we do this process, there is prevention of hypothermia in the labor room. Another procedure which we need to take in the postnatal ward as well as in the NICU is better thermal protection, kangaroo mother care, which gives us better thermal protection, increases milk production, increases exclusive breastfeeding rates, reducing the respiratory tract and nosocomial infections, improves weight, length, and head circumference of the baby, improves emotional bonding, and reduces the hospital stay. So we can see that there are so many benefits of providing kangaroo mother care. It also reduces the risk of mortality and improves growth and optimum long-term neurodevelopment. So you can see that most of the things which we need in the newborn, like protection, thermal protection, increased milk production for proper nutrition of the baby, prevention of infection, growth, all this can be achieved through kangaroo mother care. Now, if the baby is already having hypothermia, how do we manage? So if the baby's temperature is between 35.5 to 36.4 degrees centigrade, that is mild hypothermia, then we can go for supervised kangaroo mother care. This is a preferred method. If KMC is not practical, then we need to warm the room 26 degrees centigrade to 28 degrees centigrade using radiant heater or other heating device. Cover the baby adequately and replace the cold clothes with warm clothes. If the baby has passed stool, urine, and the clothes are cold, wet, then this should be replaced with warm clothes. We need to continue breastfeeding and monitor auxiliary temperature every half an hour till it reaches 36.5 degrees centigrade. Then we need to monitor it for next 4 hours, 2 hourly for 12 hours, and thereafter, and 3 hourly as a routine. If the baby remains hypothermic 1 hour after supervised kangaroo mother care, or if danger signs appear, a sepsis should be suspected and treated accordingly. Now, how do we wrap the babies? So we have seen here in the picture that babies should be clothed adequately with a frock. Then over that we can allow the baby to wear warm cloth like a sweater. Caps should be there, and then after that we need to swaddle the baby lightly with a warm cloth. So the process of wrapping is being shown here, as you can see in the lower diagram. So baby is put in a, like we need to have a square shaped cloth, and then finally with different kinds of folding that we can see here. So the baby can be swaddled properly. Now, if there is significant hypothermia, if the temperature is less than 35.5 degrees centigrade, remove clothes, cold clothes and replace with warm clothes. Place the baby under radiant warmer. So here we would need a source of radiant heat. if the baby is having temperature less than 30.5 degrees centigrade. And then we need to put the baby only on cap, socks, and mittens, but should be placed under the radiant warmer. We monitor the temperature and other vitals every 15 to 30 minutes. Now, what are the additional steps that are needed to treat such babies? We need to continue feeding. So if the baby can feed on the breast, breastfeeding should be allowed. If the baby cannot be given breastfeeding, then express breast milk through Paladi or gavage feeding should be given, because we know that babies are prone to develop hypothermia if they have hypoglycemia, if they have hypothermia as well. In case the baby has feed intolerance, we need to start IV fluids with 10% dextrose. If the perfusion is poor, then definitely the baby would need a normal saline bolus. These babies are prone to develop bleeding diathesis, so vitamin K injection should be given. Provide oxygen and monitor oxygen saturation between 91 to 95 degrees, 91 to 95%. At the same time, as we have mentioned earlier, if the baby is not responding well, looks sick, then antibiotics should also be started, because these babies are prone to develop sepsis. Now, we have concluded the part for hypothermia. The next is fever. Fever is said to be present when the temperature is more than 37.5 degrees centigrade. Common causes are environmental temperature. When it is too hot, babies become hyperthermic. Or if the baby is overdressed, sometimes parents keep the baby too near to a heater. That can also lead to hyperthermia. Babies, when they are left under heating devices, that can also lead to hyperthermia, and sepsis can be another cause. So how do we manage hyperthermia? We need to move the baby to a colder environment and let the baby be put on light clothes. Remove the baby from the source of heat. If the temperature is above 39 degrees centigrade, then sponging should be done with tepid water. So it has to be tepid water, not ice cold water, that we have to understand. Then we need to give the baby frequent breastfeeds so that the dehydration is corrected. Only if the baby cannot breastfeed, we need to give the baby with cautery, spoon, or gavage. If the baby does not tolerate feeds, then IV fluid may be given, and we need to measure the temperature early till it becomes normal. So such babies might need workup if the baby is unduly lethargic, there is excessive cry, seizures, poor feeding, persistent vomiting, respiratory distress, apneic attacks, cyanosis, all these danger signs, if they are there, then this baby would need workup and management. Discharge advice and follow-up. At home, we need to ensure that the baby is adequately covered. The mothers should continue breastfeeding. Extra care of low birth babies should be there by providing kangaroo mother care. There should be rooming in with mother, and the room in which the baby and mother are there should have a temperature between 26 to 28 degrees centigrade. Baby should be well clothed with 2 to 3 layers of clothes along with a blanket to cover the baby. Feet should always be covered as well as the head. So this is the end of our talks. So we have covered normal newborn baby, care of normal newborn baby, as well as hypothermia.
Well, thank you, ma'am. Thank you so much for the comprehensive talk. It was really informative, ma'am. So we have received one question. I have already put it in the chat box.
So the question is, what is the evidence for doing intact cord resuscitation in resource limited setting? Intact cord resuscitation. Yeah, so there are different studies which have come up in the recent years, and the most important one is by which was done in Kathmandu by a group. So they had shown that resuscitation in babies can be done with an intact cord, and this is actually helpful because during birth asphyxia we know that there is a issue of shock which can develop, and if the baby is with intact cord while the resuscitation is being done, then what happens is that once a baby starts breathing, there will be more flow of blood from the placenta to the right side of the heart, with more feeling of the left heart subsequently. as the baby breathes, the pulmonary resistance goes down. There is more filling of the lungs and more filling of the left side of the heart, and more blood to the different parts of the body, including the brain. So if there is intact cord resuscitation, that is even better. And in resource limit, this study was done in Kathmandu, as I have already mentioned, using the same kind of labor rooms that we have and same kind of labor tables that we have. So the baby was resuscitated between the mother's legs. So there is evidence of intact cord resuscitation in resource limited areas now. So we can probably do more further studies in our scenarios as well, and we can gather more information on that. So I hope the query is being answered.
Sure, ma'am. Thank you, ma'am. So, till now we have not received any other questions yet.
Mhm.
With all your permission, can I close the session over here for
Yeah,
today?
sure.
Yeah.
Sure.
Thank you so much, ma'am. Thank you so much for your valuable time. Thank you. Good night, ma'am. Take care.
Good night. Yeah.